care for patients with hemophilia continues to evolve. We've got some new treatment options, and there's also some challenges too in terms of the aging patient. And I think that's probably where we're going to start. Challenges in hemophilia care. I am with Dr. Suman Sood, who is University of Michigan Assistant Professor of Hematology. And this is an education program, and in it you discuss clinical challenges that are becoming increasingly common in the management of older patients with hemophilia. Let's talk about those first and how they impact hemophilia care.
So thank you so much for that kind introduction, Rick. So this is an exciting time in the care of patients with hemophilia because people who are older with hemophilia finally are starting to exist, basically, to be on our radar screen. The HIV and hepatitis C epidemics have basically devastated the hemophilia community. And it's very exciting that finally, as of the latest data, 13.7% of our U.S. hemophilia population is greater than 50 years old. So this is exciting times for us because we finally have people that are older, and now we get to think about all those things that older people get to face, all the same high blood pressure and heart disease and kidney disease and liver disease and all those things. We finally get the chance to address them.
Because you have to address them, plus continue to consider the hemophilia.
Exactly.
So what are the challenges that you face?
So the challenges, first of all, we know nothing about these conditions in people with hemophilia. So for example, you would think hemophilia is a bleeding disorder. So does that mean you should be less likely to have blood clots, less likely to have heart attacks, less likely to have strokes? And it turns out the data is all over the place. So some studies say you're at more risk of having heart disease, some studies say you're having less. So the first challenge is even getting a handle on what the problem is.
So in terms of mixing and matching pharmacotherapy, what do you do?
So
where's the priority?
It's a fascinating question. So obviously if someone's presenting with a heart attack, you'd think our priority is going to be treat the heart attack, so give them medicines to thin their blood. But you can't forget about the fact that they already have naturally thin blood from the hemophilia. So it's this very complex balancing act between giving them antiplatelet or anticoagulation medications to treat their acute coronary syndrome and also making sure they have enough factor therapy on board that they're not going to bleed. So it's a very delicate balancing act that we're doing, and that brings the second challenge, is that we have no evidence-based guidelines on which to do this whatsoever. So we are very much just learning about this population, learning what the problems possibly could be, and then just trying to figure out what we're supposed to do to treat this and how to balance these therapies.
What do you tell the patient? We have no idea what we're doing, but we're going to do our best.
Pretty much. That we're here with you with this, through this, and we're going to get you through this, but we're still learning, basically. And actually, that's because the reason for that, we have launched a prospective cohort study looking at people who are older, pretty much just telling them flat out, you know, we're so excited you're getting older, and we do not know what's going on in people with hemophilia in your age group. And we've gotten tremendous response. So many, we have 202 men that have enrolled in our prospective cohort study, the cardiovascular disease and hemophilia study, so that we can actually learn more about these conditions in them.
Now, another issue addressed was new long-acting factor products for hemophilia A and B. Can you talk about these long-acting factor products and their potential in clinical care?
Sure, it's a really exciting area. So as of 2014, we had two new long-acting factor products that were approved, one for hemophilia A and one for hemophilia B. And just as recently as last month, another extended half-life product was approved. So these are really exciting times. What we're trying to understand now is how we're supposed to use these drugs in our armamentarium. We have excellent short half-life products, and so at what point are we supposed to bring in these extended half-life products? Should we just use them for severe patients who need to be on prophylaxis? Should we use them just in patients with factor IX because it looks like the half-life is much longer for people with factor IX deficiency than with factor VIII deficiency? So it's very exciting times, like I said, and then the challenge basically here is trying to figure out what the steps are going forward. I think what we're learning again is that we have to be very careful about how we introduce these drugs. We don't know if they're going to be potential side effects, for example, inhibitor development. We just heard a very interesting plenary session about the risk of inhibitor development, and that means that as we start to put people on these new extended half-life products, we have to follow them very carefully and make sure that we're tracking things going forward so that we're not missing anything. But it's going to be great opportunities for patients to have to infuse themselves less and to be able to have protection that lasts longer and is greater over time. It's a very wonderful opportunity.
In terms of other agents that are in the pipeline, anything promising?
Quite a few. There's a lot going on this year at ASH, talking about these new promising agents. There's inhibiting RNAs to antithrombin. There's ACE910, which is an antibody against 9 and kind of 10, leaving out the need for factor 8. There are other products that are in the pipeline. Gene therapy is slowly making advances. And so, it could be that we get to a point where we don't need these recombinant factor products, that we're going to have other adjunctive therapies to augment hemostasis. We're quite a ways from that, but it's very exciting. The oral abstract sessions have been great, listening to all the new developments.
If we could get back for a moment and just talk about cardiovascular disease is so prevalent. And what do you do when you have a patient who has cardiac disease or atrial fibrillation, which is also very common? If you've got a patient in that, what do you do in terms of working around that or working with it?
Oh, great question. So we see this all the time when we're in the clinic, and when I'm doing inpatient rounds, these questions come up all the time. Atrial fibrillation is a little easier because that's just an abnormal heart rate. And so what we try to do is take people to cardioversion or ablation. So in other words, we're able to, rather than just putting them on an aspirin or an anticoagulant drug, try to see if we can get the rhythm basically to stop and get them back to normal sinus rhythm. So that's what we try to do in that population. That means that it's only having a limited amount of time that they need to be on a blood thinner, and then try to cardiovert them back to their normal rhythm. And so during that time, I basically support them with factor therapy so that I keep their factor levels usually in about the 30% range so that they're not at risk for bleeding while they're on that blood thinner. The question for somebody coming in with an acute heart attack, that's much more of something that it's a very kind of, like I said, tenuous balance there. What we try to do basically is put them on blood thinners, usually intravenous heparin, and again give them factor therapy to try to keep their levels above at least 60 to 80% at that point. We try to get them to percutaneous therapy with interventional therapy if they need it with the interventional cardiologist, giving them factor, giving them blood thinners, monitoring the two, trying to balance the two. And as soon as we can, we try to get them off the anticoagulant therapy. So that means that if they need to be stented, we recommend bare metal stents so that they don't need to be on
a drug-eluting stent now.
Exactly. We don't want them to be on medications any longer than they need to be. But then we're going to be wondering, how long should they be on factor replacement therapy? How high should we really get these levels to be over the long term? Was there anything that precipitated this heart disease, this heart attack?
Even without hemophilia, the conversation among cardiologists of how long to keep dual antiplatelet therapy on board is a tremendous question. Nobody can agree. Some say 3 months, some say 6. Guidelines usually say 6 or longer. Keep them on as long as you can.
Exactly.
It's a real difficult question.
Right, and so for us, we're hoping more towards the 3 months, but you're right. Many of our cardiologists want them to be on it as long as they can. And so what does that mean for our patients with severe disease? Does that mean that they need to be on factor replacement therapy if they're going to be on that aspirin? And we're really still just starting to figure these things out.
Well, thank you very much for your time. Was there anything else in the educational session that got your attention?
I think that we had a great overview, both of the extended half-life factors that we talked about, kind of these new novel agents, and then a great overview of the status of gene therapy. So, we're making progress in adenovirus-associated gene therapy. We're finally going to be entering the realm of gene therapy for factor 8 deficiency, in addition to factor 9 deficiency. And there are lots of other really interesting therapies in terms of lentivirus and other things that are coming up. So certainly exciting challenges, a lot of challenges with gene therapy, but exciting challenges.
We have a lot of coverage from the ASH 2015 meeting here in Orlando. Please check around for that. I'm Rick McGuire.